push treatment on him. Obviously with the caveat that there are, medical reasons sometimes to do treatments other than just the bother or symptoms. So, but this is very important to keep in the back of your mind. So indications for surgical treatment, failure of medical treatment. A lot of the there is no specific guide on what timeline do we consider a patient to have failed medical therapy. There are some sort of things that we keep in mind, right? So for finasteride, we're really not to know if the patient has succeeded with finasteride or is better with finasteride or really hasn't improved until about 6 months. And some insurance companies will use that as a factor to deny payment or deny a prior authorization for procedures and say that, well, this patient hasn't had 6 months of Flomax. Okay, so well, that doesn't help us as urologists because you don't need 6 months to know whether Flomax worked or not. Even though there is data that shows, Flomax improvement continues on for several months beyond a year. We really only need to have the patient on Flomax for a few days to a week at most to really know whether it's going to help them enough to be medically treated or need further treatment. So failure, desire to stop medication, or reluctance to use other forms of treatment than surgical treatments is an indication in and of itself for surgical treatment according to the AUA guidelines. And you have to also keep this in mind is that, some patients do not want to be on medication. Whatever their personal reasons may be for that are really not for us to push on them. And, some people just would rather have a procedure and not be on a daily medication for the rest of their lives. So this is an indication in and of itself. Renal sufficiency, of course, if it's secondary to BPH. Urinary retention, again, obvious indication. Recurrent urinary infections, in men, from an anatomic standpoint, should not be getting UTIs. So usually there's a reason. BPH being one of the more common ones in older folks, and bladder stones, which can cause this next one, gross hematuria, or a lot of irritation or recurrent UTIs, and so on. So these are the indications we keep in the back of our mind, but really the first two are the most common reasons that we come across. So I wanted to share this. So you can see on the left is a very long list of included procedures in the AUA guidelines. And you can see that they're actually quite strict with what they consider to be a very high or a level of evidence. And none of the procedures actually reach that, according to the AUA. Now, this is where the European guidelines actually differ, perhaps they are less stringent, or their criteria for what's considered level 1A evidence or level 1B evidence is different. But essentially, there are a lot more procedures that are considered to have good evidence to support them according to the European guidelines compared to the AUA guidelines. So even procedures that we really feel are very well supported by the guidelines, such as TURP, HOLEP, and simple prostatectomy, have very strong long-term data, and even those all get B recommendations, which according to the definitions in the guidelines means should better data be available, our recommendation might change. If the evidence level was an A, then that would mean that probably new data or better data is not going to change our recommendation. So none of those reach that level according to the AUA guidelines. So also something to keep in mind. So a couple of these here before I go on. So embolization and tuna, needle ablation, not currently recommended. My intuition is based on some of the evidence that's coming out that Dr. Bojani will talk about in the second part, embolization is probably going to become recommended at some point and take some of that BPH volume away from us. But we shall see about that. So, so surgical therapy. So this is a copy of the very nice algorithm that the AUA guidelines include. So the first part of it is really assessment of prostate size. So there is a specific statement lines that says that DRE really is not a good indicator of prostate size and probably should not be used as such to guide therapy. And this is important, right? Because we know that there's old data out there that when you have a medical student and a resident and an attending doing a DRE, there's really no correlation between what they estimate the size to be and no further correlation with what the actual size of the prostate is by transrectal ultrasound. So DRE is important for finding nodules, for assessing abnormalities, but probably not a great assessment of prostate size. And we'll get back to this algorithm in just a second. So let's say you have a patient now that you are has failed medical treatment or doesn't want to take medical treatment or fits one of the other criteria, and you want to assess their prostate size and shape. And the shape part is also important, and that's one of the things that has become more prominent in the guidelines as time has gone on. And that comes as a quote unquote consider statement, and but does that mean that it's not 100% necessary? Possibly, but from a medical due diligence standpoint, probably these are good things to have in your preoperative evaluation. And for some of the procedures, it's almost necessary for us to be able to document certain aspects, which we'll get into in a second. So cystoscopy helps us to really look at the shape of the obstruction and also to rule out sort of median lobe. We can look at trabeculations. We can look at diverticuli and so on. So that gives us a lot of information. And then we need to look at the volume of the prostate, and we can do cross-sectional imaging. Of course, we can look at two planes and get three measurements. And using I just Google ellipsoid formula and to get a rough idea that generally will overestimate the volume compared to the transrectal ultrasound I've found. There may be some data out there on that. This is just my anecdotal observation. The transrectal ultrasound tends to be quite good. So in my practice, what I've generally done is once I have a patient who is considering an operation, then I just have them come in for a procedure and we do a cystoscopy and a transrectal ultrasound in 5 minutes. We let them get dressed and then we go through the options based on the results. So according to the guidelines, you should get a PVR. And this is really so more for the purposes of documentation, I find, because they do then go on to mention that a PVR can be quite variable, and there, from person to person, from time to time, and from void to void, it can be quite different. So I haven't found personally the value of a PVR in a patient who is going to surgery. I found it more valuable in patients who are not going to surgery, because then you can use that as an option, as a parameter to monitor, frequency of CIC and so on. So Uroflow is another consider study, and it does give us a good amount of information and gives us another parameter to judge our procedure results by, or even our medication results by. But it's something that you do have to, consider with the Uroflow, is that you have to have 150 milliliters of voided volume to really get a good result, a generalizable result for the Uroflow. So That's important to consider. And then also there's cost. So Euroflow is not free. It's widely available and widely done, but it's not free. So if you do have indigent patients or cash patients, you can see if maybe that is necessary to your evaluation, or it was not going to make a difference to your recommendations, then maybe it's not necessary. So the guidelines will tell us the pressure flow study is a consider statement if the diagnosis is uncertain. So this is kind of a catch-all statement, right? This is one of those clinical principles or expert opinions that don't have a lot of data behind them necessarily, but we've been doing it for a long time, and so it can sometimes help from a diagnostic standpoint. So just wanted to make a quick side note on bladder contractility. So the reason why pressure flow study a lot of the time comes into play is because we're afraid that there is going to be a small percentage of patients who really have a very hypotonic or atonic bladder, and they're really not going to be able to void after we open up their obstruction. This is obviously comes into play more with patients with neurogenic bladder for various neurologic conditions or spinal cord injury and myelomeningocele and all that kind of thing. But if we're talking strictly about the non-neurogenic standard BPH type patients, then in general, there's a couple of different ways that you can assess, whether they have a good chance of voiding postoperatively or not. And I'll show you some data here in a second about that. So we can just assess by history. So if patients are spontaneously voiding to some degree, the vast majority of those patients are not going to be in retention after you relieve their obstruction. That seems fairly obvious, but you don't necessarily need a urodynamic study to tell you that if you know that the patient is voiding spontaneously. Informal testing. So there's one of the other, COVID type lecture series. There was a talk done by another previous Indiana fellow, Mike Borofsky, and on this topic. And he was saying that his practice when he's evaluating the patient preoperatively with a cystoscopy, he'll just make sure to fill the bladder with 250 milliliters, and then he will have them try to void afterwards. If they can void, then he tells them that their likelihood of being in retention or not being able to void afterwards is really pretty minimal. And then, and within urodynamics, there are a couple of these indices that we can use if you really want to get into the nitty gritty of it, or if you really are uncertain on how to counsel a patient and give them just some hard numbers. But these have somewhat limited applicability in clinical practice, I think. So this is a study I wanted to share out of Indiana. Well, I think actually Dr. Krambeck was at Mayo at the time, but so she's probably the highest volume whole lip person in the U.S. At the very least. And so there's some data here that essentially is showing she had patients who for non-neurogenic bladder underwent whole lip, and they had a detrusor underactivity or acontractility on urodynamics preoperatively. They had whole lip done, and really all of the men afterwards were able to void spontaneously to some degree. Some of them needed to use intermittent cath, but were voiding in between. And so, this really shows us that even when you show underactivity or acontractility on urodynamics, the vast majority of those patients are going to be able to void post-op. And a lot of this is going to be about setting expectations correctly. Okay, so a couple of the things that are specifically mentioned in the guidelines in the algorithm are going to be, quote unquote, medically complex patients, people who can't undergo anesthesia. And this is where some of the newer procedures come in that can be done under sedation or just under local with in the office. And that's just a great thing to have in the armamentarium if you have that available and if you're comfortable doing it, of course. Doing procedures on um, I think there was a question. It popped up in the corner here. Would you do the same? That study was for HOLEP. Would you do the same for PVP? And I think I didn't mean to show it just for HOLEP. I think that that principle applies for all procedures where you are really trying to open up a nice channel for the patient to void from. So I think PVP would apply. And I think most of these procedures would apply. Um, that principle should apply to. I don't know how to find the rest of that question, so maybe we can come back to it later. So the second part of medically complex, so can't stop anticoagulation. So there are three procedures here that are very hemostatic, HOLEP, THULEP, and the green light laser ablation that are approved for that as far as the guidelines go. And I think, I've seen that in practice during training, and it seems to work quite well. So this is the part of the, the screenshot from the guidelines. And the other part is really where where the patient is very concerned with sexual function, erectile function, and concern for antegrade ejaculation. And that can be a consideration which really points you towards a different direction than, let's say maybe a TERP, where you're expecting a close to 75% rate of retrograde ejaculation. Okay, so back to the algorithm. And so now we have the small prostate, the quote unquote small prostate. The guidelines don't actually define what they consider to be a small prostate. But in general, if you look at the BPH literature and talks and stuff that people give, generally they're looking at 30 milliliters or less. And the algorithm is there's a lot of overlap, right? So you can do a HOLEP for a 25 milliliter prostate. There's not going to be a lot of tissue that you enucleate, but you can certainly do it. Same thing with PVP. It seems the best bang for your buck in maybe the medium size 60 to 80 gram prostate, but can you do it in a 30 mil? Sure, you can. So there's a lot of options here in the 30 mil or less category, and that's going to cover actually probably the bulk of our talk today. So to get a couple of these procedures out of the way first, tuna, needle ablation. So this is actually not recommended by the AUA guidelines. The European guidelines are different. They actually do show data where tuna does decrease your IPSS scores and it does increase your Qmax. It's not quite as good as TERP, but it does work, for lack of a better word. The reservations that the AUA guidelines have against it, that the results were felt to be inconsistent and that it was poor efficacy. So what they found is that it kind of just turned the prostate into a sort of a mess of scar rather than really reduce it or removing the adenoma and opening the channel significantly. So a little bit of a difference of opinion here. So this is actually from the European guidelines. You'll see on the right side that they seem to feel that this is pretty high-level evidence for a tuna. But you really don't not find this much in the U.S. Nowadays. So moving on quickly from that, you have the microwave therapy. And again, this is quite limited availability here in the US. I'm not sure about Europe. The guidelines here, I thought that, mistakenly thought that it was not recommended, but it may be offered with the caveat that there is a high retreatment rate compared to TERP. And that retreatment rate we'll get into in just a second because there are some contention with that, but certainly a 10% retreatment rate, they say over 3 years would be quite high. But hard to find this in the US nowadays. And of other options available. There is excellent data to support the use of the transurethral incision for smaller prostates. Of course, you get a lower risk of retrograde ejaculation, so this may be better for the sexually active person who's concerned about antegrade ejaculation, who's on the younger side of things. And just a side note here, if you actually look at the guidelines, their index patient is anybody over 45 years old. We tend to think of the BPH population really as Medicare and plus age, 65 and older, but there's a significant portion of patients with BPH, with obstructive prostate, that are significantly younger than that. And, these issues do come into play a lot more with that population. And for the older one, but just more so. So this is something that you can offer. It's a quick procedure. So, for the sicker patients where you're just trying to open a channel and be done, this may be again considered. So monopolar TURP. So this is really the gold standard, right, by which all of our other therapies are measured. We use hypotonic irrigation, as we know, because of the way the electricity is traveling and the way it's grounded. And because of the hypotonic irrigation, we really want to limit this procedure 60 to 90 minutes. The risk of TUR syndrome is there. It exists. Almost everybody will have seen a case at some point. It's less and less common nowadays, about 1% in modern series for the monopolar TURP. But it certainly does exist, right? So the issue there is delusional hyponatremia, and it's the diagnosis postoperative neurological symptoms, confusion, somnolence, and potentially coma. This is obviously in the immediate postoperative period. This can be hard to differentiate from just post-anesthesia presentation. So it's something to watch out for if you are doing a monopolar. The treatment is a slow, and that's the operative word, is slow correction of the sodium using hypertonic saline to prevent central pontine myelinosis. So moving on from that, historically the transfusion rate is presented as around 4 to 5%, and again that in modern series you might see that a little bit less, and especially as we move away from monopolar TURPs. As a specialty, we've seen those transfusion rates come down, but that's still what I quote to patients again as a tool for management of expectations. So 2 to 3% retreatment rate is what is given in the guidelines. So bipolar TURP, there's several head-to-head studies that really show no difference in the efficacy in the change pre-op to post-op of the IPSS score and the Qmax, the flow rate. And obviously, if you have a bipolar instrument, you're going to have less hyponatremia. But also, there's data to show that there is less bleeding. There's a shorter catheterization time. And the transfusion rate is quite a bit lower. So pushing against 3%. So the guidelines then go on to say that a bipolar TURP, because of these improvements in outcome, may be preferred for the larger glands. Overall, in general, TURP is recommended for small to medium, small to average prostates, as they call it. So a couple of things that I wanted to point out. So this is a study that is heavily referenced in the European guidelines. And what they talk about here is at an average of, or at least 10-year follow-up, there is a 6% repeat operation rate, and that includes repeat treatment of the adenoma as well as endoscopic treatment of any bladder neck contracture or stricture and so on. So, so that's not insignificant, but it's relatively low compared to some of the other therapies we're going to talk about. And the The mean IPSS score was 4.9. This is at 10-year follow-up, so that's very low. That's very good long-term efficacy, and the quality of life score was 1.2. So again, quite good. So these are things in favor of TERP. But another study that is heavily referenced in the European guidelines shows that at 8 years, the overall incidence of a secondary procedure, including complications and retreatment of adenoma, was almost 15% for TERP. Now, it's possible that, you know, well, this is a little bit concerning, of course, for TERP. So it's always good to again set expectations that there's definitely a non-zero rate, right? TERP is not a one and done, and there is a timeline on regrowth of adenoma or recurrence of symptoms. So these are two studies which are quite large and with good follow-up, so that those can be quoted. So bipolar vaporization. So this is like the button. So it may be offered. That's the statement in the guideline. It's comparable efficacy to TERP in the studies that have been done. Presumably, these were relatively well-selected patients. Because I think the larger the gland, the more challenging it can be sometimes with vaporization to really get a good opening of the channel. And at the end, maybe we can have a poll or some of the folks who have seen the evolutions in BPH come and go, maybe comment on this, because I'd be interested to know what everybody thinks. But certainly there's no doubt that there's a decreased risk of bleeding and transfusion with the button or the transurethral vaporization. Okay, so prostatic urethral lift. This is one of the newer guys. Well, we say newer guys, but been around for 7 or 8 years now. We have good data on it in the medium term. So really, as far as the guidelines are concerned, this is used for small to average prostates, less than 80 milliliters, and they have to have no middle lobe, no median lobe. And cystoscopy really is the way to document that and not be surprised. Now, of course, given that more experienced surgeons are doing prostatic urethral lift in patients with median lobe, that data is going to change. There's going to be studies coming out with data on patients with median lobe, and I'm sure it will show that to some degree those patients do well as well. But if you are starting out, as I am, I haven't done too many of these. I don't offer this to patients when I see a median lobe. And again, from your own sort of safety standpoint, it's not recommended in the guidelines. So unless you really have a good understanding of how to treat a median lobe with this procedure, it would not be recommended do so. So really what they are, for those who don't know, so it's just a suture with a tag that you are firing into the adenoma. It latches onto through the capsule and pulls the tissue, pulls the lobe laterally. And what you're trying to do is create a continuous anterior channel for the patient to urinate through. You're not removing any tissue, although there may be some necrosis, pressure necrosis of the tissue on where the suture is compressing, but really you're not reducing the volume of the prostate. You're not reducing the size and volume of the adenoma. You're just creating this channel, and so that really should clue you in that probably this is not going to last quite as long as a TERP might. So, the symptom reduction, the IPSS score reduction, and the flow rate improvement are significantly decreased compared to TERP, right? And that's really not the way to think about this procedure. hey, this is equivalent to TERP, or it's that this is not equivalent to TERP, and therefore it's an inferior procedure. Really, this is a game of pros and cons, and there's a lot of caveats that come with recommending this procedure to a patient. So, the outcomes, the bare bones outcomes are worse than TERP. The retreatment rate, as far as we know, and in the studies, the follow-up is reasonably good. It's 13.7% at 5 years. That's not insignificant. That's a lot. And we don't know anything about the long-term efficacy. That's only at 5 years. So there are a lot of caveats as far as effectiveness goes. However, the biggest thing with this procedure is that there's really zero risk of sexual dysfunction or de novo erectile dysfunction, which in the TERP series is about 4 to 5%. So this is something that, like I said previously, this is a significant concern for some patients, and you have to honor that if that's their concern more than the efficacy of the procedure. So there are two main studies that usually get cited. There's the LIFT study and the BPH6. So the LIFT study was the 5-year results. And so what you can see here is that the IPSS score on average went from 21 something to almost 14. So 14 falls in the moderate range. So it's not that patients are perfect afterwards. And this 14 is actually relatively steady from this is the 5-year data, but it's relatively steady from 1, 2, 3, 4 years as well. So you're not going to be perfect, most likely, if you're the average person getting a UroLift. The quality of life is down to 2.3, and I showed you the long-term results for TERP are 1 point something. So again, the quality of life score is not quite as good, but 2 is okay. Two most people can live with 2, and the flow is not high compared to what it was before. Not a great deal of improvement. So really, you have to give all these pros and cons to the patient, because if they are expecting that they're going to pee perfectly for the rest of their life after a UroLift, you've really done them a disservice with your counseling. The BPH6 study was they had taken a 6-question, sort of a composite questionnaire that they created from previously validated questionnaires, and they were trying to look at the UroLift results more holistically and compare them to TERP. So what you see here is that the change in the IPSS and Qmax in the TERP arm were superior. We already knew that. We already knew that from the LIFT study. The improvements in IPSS quality of life and BPH2 score were not significantly different between the study arms, but they were better in the TERP arm. It didn't reach statistical significance, but I wonder if you had it sounds if sorry, I lost my train of thought. They were not statistically significant, but they were better. And I bet if you had more than 30 something patients in each arm, like they did in this study, you might be able to show that. But having said that, again, UroLift, superior quality of recovery, ejaculatory function preservation, and sexual performance. So
فراس ايه بس معليش يعني طولت السالفه طولت انا المفروض يا رجل من الساعه 2 وانا مخلص شغلي.
Another thing I just wanted to mention here is the shim score at 2 years in this study. So there's really zero difference in the prostatic lift, in the UroLift, whereas there is a little bit of a difference here, not quite reaching statistical significance in the TERP. And again, with more numbers, you might see that there's actually a difference in the shim scores at 2 years or with more patients. So I saw a comment pop up is that it sounds like you're not in favor of UroLift. It couldn't be further from the truth, actually. I really like the procedure. I think it's wonderful. I have had excellent results with it. I just think that you have to be very, very careful in what your expectations are for the patient, what the patient's expectations are, what your expectations are, and really what you're selling them. But I really like it. And then the few patients that have had it done with me thus far, I think we've been able to select very well. And actually, to a man so far, knock on wood, they've done extremely well. So I'm very much in favor of it. So Dr. Bajani will talk about the resume, the water vapor thermal therapy in part 2, and we'll move on then real quick to the average prostate side. And like I said, a lot of overlap here. And so the one that I will mention is the PVP. So this is vaporization of tissue with a specific wavelength laser that's going to be absorbed by tissues with hemoglobin. So that's why this ends up being a very hemostatic procedure. And the actual efficacy as far as urinary parameters go, it's equivalent to TURP for the smaller volume prostates. There isn't specific data, I think, comparing for the average size prostate, but certainly we know that the risk of transfusion is much, much, much better. And that's why it's actually recommended now for in the guidelines for the anticoagulated patients who can't come off their anticoagulation. Aquablation, a newer treatment, it very much is up in the air as to what the medium and long-term outcomes and complications of that procedure are going to be. The 1 and 2 year results seem to be equivalent to TURP. I think that Dr. Bajani will talk about it, so I'll let him kind of lead the conversation on that one, as well as on embolization. So one thing about the minimally invasive surgical treatments, the missed treatments as they were. So the primary goal of treatment, like we said at the beginning of the talk, is to alleviate bothersome LUTs, right? So, and we know that the minimally invasive treatments do not alleviate bothersome LUTs to the same degree that our gold standard TURP does. Therefore, we really have to have so a different risk profile, a different set of sexual side effects, or a different set of expectations for those procedures. And as long as the patient and the surgeon are both on the same page, I think those are definitely good options to consider. Okay. So moving on then to the large prostates, and there's really only 3 things here, and we're only going to talk about one of them today. The simple prostatectomy has been around forever. This is really the preferred way to treat the larger prostate when it was too big for TURP. Although I remember in residency, one of our attendings said, there was very routine for them to do TURPs on 100 to 150 gram prostates. They just got very, very good at it. So I think it's better that we have more techniques available to us. So the approach, whether it be lap or robotic or open, is dependent on surgeon training and preference, as always. So there are 2 sort of approaches, retropubic or suprapubic, and that will determine kind of what kind of access you have to the bladder and any kind of bladder pathology if you are trying to treat that at the same time, or if there's a median lobe. So the robotic approach, and the lap approach for that matter, so the pneumoperitoneum is going to lead to decreased bleeding, and that's always a plus for patients. On the other hand, probably there is an increased complexity to the procedure. Cost is definitely something we always are considering nowadays, which is increased with robotic procedures, and time, right? These are not short procedures. Certainly, the more you do, the better you'll get at it. But I think that they are relatively long procedures. And now we've done a few of the single port simple prostatectomies at URMC between the minimally invasive surgeons, and it seems like the patients do great. They have a tiny little incision at the belly button, and they go home the next day with a catheter, and it's a new wave. It's another innovation and evolution in BPH treatment. So it's great. Always good to have more options. So this is again from the European guidelines. This is a nice table of the larger studies that are there for simple prostatectomy. This will get updated. There's a lot of data coming out with the robotic procedures now, and nothing head-to-head between robotic simple and HOLEP. No, there are a few. I take that back. There's a few out there. And the results seem to be quite equivalent. And the bottom line for these enucleation type procedures, whether it's the simple prostatectomy or the HOLEP or THULEP, is really that because you are taking out such a large volume of adenoma, this is where you get the biggest absolute changes in your IPSS score and in your flow rate, and also the durability of the procedure is much higher than the other endoscopic procedures we've talked about so far. So the last thing, so HOLEP and THULEP also Naeem's going to talk about. The last thing I wanted to leave you with is this table, which is kind of at the end of the European guidelines, which I found quite helpful, is just a listing of the various procedures and their, quote unquote, onset of relief of obstruction and the degree of, improvement in, my top part here didn't come through. So this is IPSS, Qmax. I think this is volume reduction. But anyway, you find that table at the end of the European guidelines. I think it would be quite useful for the residents to have all of the information together in one go. So I wanted to leave you with that one at the end. So thank you so much for your time. Thank you to the Urology Teaching Collaborative. Very nice. Thank you. So I think Naeem said, why no PVP for large glands? So I was at Cleveland Clinic for training, and Jim Alshaker is there, and he has a very high volume of PVPs, and I sat in with for a couple of procedures with him, and he actually does an amazing job with PVP for pretty large glands. I think he'll go up to 200 grams. And he does an amazing, beautiful hemostatic procedure. He sends, he keeps the catheter in for a few hours post-op, and the patient goes home without a catheter, actually, or maybe, with some of them, he has them take them out the next day. So I don't think there's any problem with doing PVPs in large glands. I do think that there used to be a concern that with the green light, especially the higher power lasers, there can be a pretty high risk of patients having a lot of irritative symptoms that can be more or less permanent and very, very bothersome, and that seem to correlate with the larger volume and the more ambitious and heroic ablations. So it's not in the guidelines for PVP for large glands, but I think that in the right hands and if you're comfortable with it, I think there's no reason why not. The question, transurethral bipolar enucleation. I've seen the videos. They look very nice. It is, I think, very challenging in the current healthcare environment, as you all are probably seeing, that capital expenditure is kept on a very tight leash. So there are competing interests that you have a procedure that you are comfortable with, and you can continue to offer that to patients with good confidence. And then how do you bring a procedure in to try something new without sort of having to commit to a $100,000 capital expense or $300,000 capital expense, where you then have to justify that for how long? I don't know. So I think with BPH specifically, there are so many technologies that it's tough for one institution to really try everything. But to answer your question in short, no experience with bipolar enucleation. But I think there are some centers in the U.S.
There's another question that says, how low of a pressure in a hyporeflexive bladder still qualifies the patient to undergo an outlet procedure? So is there a cutoff you use?
I don't really use a cutoff. I honestly just see if they have some spontaneous voiding, and they are if they have any kind of spontaneous voiding prior to the procedure, and they understand that if we relieve the obstruction, that they may still have to do some intermittent cath, then I think then our expectations are on the same page.
There's another question about evaluating a patient with cystoscopy prior to a prostatic urethral lift. What's your strategy for managing the high bladder neck?
Yeah, honestly, I don't claim to be on the urethral lift, so I do defer, sometimes to the guys that come in. They can guide you because they've seen literally thousands of these procedures sometimes. And when you have the high bladder neck, you have this risk that if you put a suture very close to the bladder neck, you can kind of fish mouth the opening and actually in some ways worsen your outlet. But I think if you keep your suture back a little bit from the bladder neck, then you can still get a nice opening with the high bladder neck. But yeah, I mean, it doesn't preclude you from doing it, but you do have to be careful where you put your proximal suture. You leave a catheter in after PUL? No. I have not had an issue with voiding afterwards. And I have done it in a couple of guys who were, in retention pre-op and were able to void afterwards. So again, I think it's about patient selection and expectation. Well, great. Thank you so much, everybody. Really appreciate your time.
Awesome. Thanks so much, everyone.